Good evening, guys. I've got discussion D for you. We're discussing frailty in older adults. So this falls under gerontology for me, which is a study of geriatrics. Okay, so here we go. A study led by Dr. David Ward at the University of Queensland, published in JAMA Neurology, analyzed data from nearly 30,000 participants across 4 UK and US longitudinal studies. The research revealed that frailty, defined by the accumulation of age-related health issues, is a significant predictor of future dementia. Frailty leads to frailty tends to accelerate up to 9 years before a dementia diagnosis, suggesting it's not just a result of cognitive decline, but a contributing factor. Specifically, every 4 to 5 additional health conditions corresponded to an average 40% increased risk of developing dementia. Early detection and intervention targeting frailty could be a crucial strategy for dementia prevention. This supports a shift toward broader systems-based risk assessments in cognitive health. Would you like to delve into how this might intersect with other biomarkers or non-pharmacological interventions you've been exploring? Frailty's connection to cognitive health is profound. It's shifting how we think about dementia risk and prevention. Here's why it matters. Frailty as an early warning signal. Rather than being a consequence of cognitive decline, frailty may precede and contribute to it. The fact that it accelerates nearly a decade before a dementia diagnosis reframes it as a preclinical marker, giving us a broader window for intervention. To a whole person systems level risk factor. Unlike single biomarkers, frailty reflects cumulative defects across physical, psychological, and sometimes social domains that makes it a holistic indicator of system vulnerability. Uh, Silos between genetic, geriatric care, neurology, and preventative medicine. 3. Intervention opportunities. Because frailty is modifiable, it opens the door to targeted strategies like resistance training, protein intake optimization, vitamin D supplementation, fall prevention, and polypharmacy reduction that may reduce both frailty and dementia risks simultaneously. Okay. 4. Implications for dementia prevention trials. Most trials focus on amyloid or tau pathology, but frailty offers a complementary framework. Future research could explore multi-domain approaches that integrate frailty measures alongside neurodegenerative biomarkers. Equity and access considerations. Frailty disproportionately affects those in diverse disadvantaged populations due to higher burdens of chronic illness and poorer access to care. Addressing frailty may help close gaps in dementia risk prediction and prevention, especially among underrepresented groups. It's a striking reminder that protecting the brain might be might begin with strengthening the body. Would you like to explore how frailty scores could be integrated with personalized cognitive assessments or care models? You're investigating, like agency with choice or nurse-led approaches in clinical settings. Frailty is typically assessed using structured tools that evaluate cumulative defects across multiple domains: physical, cognitive, and functional. Here are the most widely used approaches. Okay, number one, frailty pentotype. Uh, Fried criteria. This model identifies frailty based on the presence of three or more of the following. Unintentional weight loss, self-reported exhaustion, weak grip strength, slow walking speed, low physical activity. It's especially useful for identifying physical frailty in research and geriatric clinics. 2. Frailty index. Rockwood accumulation of the defects model. This approach counts a wide array of health defects, chronic conditions, symptoms, lab abnormalities, and functional impairments to calculate a frailty score. The more deflects, the higher the score. It's sensitive and scalable idea for electronic health record integration and personalized risk profiling. Clinical frailty score or scale. A 9-point pictorial scale ranging from 1 very fit to 9 terminally ill, based on clinical adjustment. It's fast and user-friendly, widely used in acute care, palliative settings, and triage decisions. Okay. Admiration frail scale and frail questionnaire. These tools incorporate domains like cognition, social support, and medication burden, making them valuable for community dwelling, older adults, and a multi-dimensional screening. Each tool serves different contexts. Some prioritize rapid bedside assessment, others are better for comprehensive evaluation or longitudinal monitoring. Would you like to compare how these measures perform in uh, predicting dementia risk specifically, or how they might inform personalized planning models like agency with choice? Frailty assessments are powerful predictors of a wide range of health outcomes in older adults, often more telling than chronological age alone. Here's how they help forecast what's ahead. One, mortality risk. Higher frailty scores are strongly associated with increased short and long-term mobility, even after controlling for other health conditions. Tools like the clinical frailty scale are frequently used in triage and palliative care planning for this reason. 2, hospitalization and readmission. Wait a minute, guys. I'll be right with you. Having an issue here. Frail individuals are more likely to be hospitalized, have longer stays, and face higher risk of readmission. The frailty index is particularly effective in predicting adverse events during and after hospitalization. Post operative outcomes. Surgical teams often use frailty scores to assess whether an older adult is likely to recover well from surgery. Frailty is linked to increased post-operative complications, including delirium, infections, and loss of independence, functional decline, and falls. Assessments like Fried uh, phenotypes or phenotype can identify risks for mobility loss, disability, and falls, enabling timely interventions like physical therapy or environmental. Hold on, folks. Environmental cognitive deterioration and dementia. As highlighted in the article, frailty progression can precede and predict cognitive decline, reinforcing its value in early dementia risk satisfaction, especially when combined with other non-invasive markers. Medication management and polypharmacy risks. Frail individuals are more vulnerable to adverse drug reactions and prescribing cascades. Frailty screening supports tailored the prescribing and medication reconciliation. Would it be helpful to walk through how frailty screening could be integrated into agency with choice models or used to stratify risk for personalized prevention? Plans. Frailty assessments serve as clinical or critical touch points in healthcare planning. They help clinicians move beyond age alone to truly anticipate in older adults' care needs and trajectory. Here's how they shape planning. Personalized care strategies. Frailty scores allow providers to tailor interventions such as prioritizing physical rehabilitation, nutritional support, or deep prescribing based on an individual's resilience and risk profile. 2. Informed shared decision making. By quantifying frailty, clinicians can have more nonsense conversations about risk and benefit treatments, especially high stakes ones like surgery or chemotherapy. This aligns care decisions with patient preferences and realistic outcomes. 3. Proactive resource allocation. Health systems can use frailty data to better allocate home care services, transitional care support, or case management resources, targeting those at high risk for deterioration or hospital readmissions. Care coordination and transitions. In models like agency with choice, frailty assessments can help guide when to bring in additional supports, trigger care transitions, or build structured routines that prevent burnout and preserve autonomy. 5. Palliative care and end-of-life planning. The clinical frailty scale, for example, is frequently used to identify patients who may benefit from advanced care planning, or palliative consultation earlier in the disease course. Frailty, in essence, is a strategic lens for designing care that not just reactive but anticipatory and person-centered. Would you like to explore how frailty assessments might be integrated into data-driven risk? Older adults and caregivers. Frailty demographics due to biological, social, and structural factors that influence both how frailty manifests and how it's measured. Here is a breakdown of key variations. Age and life course contexts. While frailty is more common in those over 65, early onset frailty can occur in marginalized populations or those with chronic disease exposure, often starting in midlife. This requires recalibrating screening tools to be sensitive across the aging spectrum. 2. Sex and gender differences. Women often score higher on frailty scales or indices, largely due to longer life expectancy and higher rates of disability, but many live longer with frailty. Many appear less frail by physical matrix but are often higher risk of mortality and at any frailty level, suggesting potential under detection or differing trajectories. 3. Race, ethnicity, and cultural considerations. Okay. Certain tools may over or underestimate frailty in diverse populations if they don't account for baseline differences in physical function, language, or health behaviors. Structural integrities like unequal access to care or neighborhood safety can accelerate frailty progression in underrepresented underrepresented racial or ethnic groups. Societal economic status or SES. Low SES is associated with earlier onset and faster accumulation of frailty due to chronic stress under nutrition and poorer healthcare access. Tailored tools like the multi-dimensional prognostic index may better capture this complexity. 5. Racial versus urban living. Access to healthcare and support systems affects frailty recognition in rural areas. Underdiagnosed is more common, and assessments may rely more heavily on informal caregivers or community health workers. Cognitive and language diversity. Some frailty tools rely on self-reporting or clinician observation. In populations with cognitive impairment, low health literacy, or limited English proficiency, adaptations or proxies may be needed to ensure valid assessments. All this underscores the need for flexible, equality-informed frailty assessments that can be calibrated into the lived realities of diverse older adults. If you're considering how these demographic nonsense could help in assessments, let me know. Okay, guys, so that is it for tonight. And we'll see everybody tomorrow for shows. Until then, Gator Wellness, take care, folks.